So, you're pointing at each other. I love it. Well, the bad news is it is 106 outside for a high. Yes, it's a dry heat, they say. It's funny when people say that because it's supposed to make it not so hot. No, it's hot. Everything after 100 is just hot. You still sweat. The good news is we are here in this beautiful ballroom with a crisp, I want to say 65, maybe 70 degrees from our wonderful air conditioner. And we have another day of fascinating and interesting speakers and events lined up for you. So without further ado, let's get started. Please put your hands together for our first speaker. Please welcome Amish Purohit, CEO of U.S. Health Systems, and our physician. Come on up.
Okay. Mic's working. Okay. Thank you. Good morning, everyone. Okay. Well, it's always hard to compete with Las Vegas and all the distractions. So if you're not here, you're either hungover, you're still partying, or you're still gambling. So for all of you that are here, I appreciate you being here. Otherwise, I'd be speaking to myself this morning. So thank you. This morning, what I want to talk about is population health. And I have about 40 slides, but I'm not going to go into detail with all the slides, but I do want to leave you with a conceptual framework of what population health is, why we do population health, okay? Why is it important to the U.S. healthcare system? So, the first question in the room, how many providers, nurses, doctors, PAs, okay, with these bright lights in my face, I can't see how many hands, but there's a few of you out there, okay. How many tech partners do we have from the technology space? Raise your hand. Okay, good. And then how many hospital systems or hospital partners do we have? Okay, one. Okay, all right. How many patients do we have in the room? Every hand should go up, okay? If you're not a patient, you should be. You should be getting preventive care. You should be seeing your doctor. Part of our problem in the U.S. is cost, quality, and access, okay? All this population brouhaha is coming because we historically have not done a good job in this country in terms of outcomes, in terms of cost, in terms of access to care. So if you look at the first slide, I'd like to start off with a cartoon. You want to play doctor? Person says, no, you don't have insurance. Okay? That is a huge issue when you can't have access to health care. And this is from 2014, but 55% of our population, no usual source of care. Okay? Even the ones that have insurance, whether it's commercial, whether it's Medicaid, whether it's Medicare, they still don't seek care. Why? There's a cost burden. Okay? They delay care because of the cost associated, whether it's the high deductibles, the co-pays, the cost of prescription drugs. So access is a problem. Okay, so remember three things: cost, quality, access. What do we spend? We were talking about cost, percentage of GDP. Look at the U.S. as compared to the other economically developed countries in the world. We spend more of our dollars on health care than any other country in the world, okay? It's a problem. The problem with that is our outcomes aren't any better. Now, this is a slide that just shows that people over the age of 18, how many of them are seeking care in the ER, where you could have had your care delivered by your primary care doctor on an outpatient basis, okay? The cost to getting care in the emergency room is about 10 times higher than the cost of getting care at your primary care doctor's office, okay? If you go to the ER and you get admitted, we're talking about 100 times greater cost for taking care of that patient, okay? Look at the Medicaid spending. We're hitting over close to $1 trillion. So our costs continue to go up. This slide, I know it's busy, but what to take away from this are outcomes for the level of spending that we have in this country. We're not achieving the outcomes that we want. Our life expectancy across the world is lower compared to the other nations that are spending less on healthcare than we are, okay? So that's a problem. All right, so why do we have this issue in the United States? And it goes to premium medicine. Healthcare in this country is expensive, okay? And there's a couple of reasons for that. We spend a lot more money in physical capital and human capital, okay, than we ever have before. One of the things in this country we try to do, and if you talk to our physician partners or clinician partners in the room, we want to be accurate with our diagnosis, okay? Patients demand accuracy in diagnosis. They don't want to go, if there's a test that may give you a very small percent incremental value, it gets marketed as this test is better, but the cost is tenfold, okay? So the expectation and the culture in our society is we want a high level of effort to diagnose correctly the conditions and making sure that we're accurate. So there's a cost to that. Can we afford that cost? I don't know. Do we get the value from spending those additional dollars? No, we don't, okay? So, and then the other thing I'll ask you is how many of you, when you start paying your bills, you're paying your mortgage, you're paying your car payment, what's the last thing that you guys pay? Someone said it, healthcare. When you get a bill from your doctor's office, the first notice comes in, great, they'll send another one. They don't pay it right away, okay? The second notice comes in, gets chucked. Third notice comes in. Then they're going to say, hey, we're going to send you to collections. They're like, oh, you know what, I better pay it, okay? We have the mindset, we want Cadillac care in this country, but no one wants to pay for it, okay? That's a problem. There has to be cost share. Now, the other thing about, we talk about cost share, you know, we talked about access. What happens with the uninsured or the people that don't have insurance when they go to the emergency room? Who bears the cost of that care when that patient gets admitted and there's no reimbursement to the hospitals? Well, no, not really the insurers. It's the American consumer that's buying health care. They cost shift. So the hospitals, if an uninsured patient comes in, they're not going to take the brunt of that cost. They're going to push that to the paying population. And what happens there? The premiums for the health insurance companies go up because now the consumer that has insurance is being charged money. So there's a lot of cost shifting going on. And eventually what happens is your premiums go up, okay? An employer, you guys, if you have your own business or if you're employed, just ask your leadership. Look at what your cost in premium, if you're not self-funded or partially self-funded, what is your increase in premium for health care for your employees? Okay? Just think about it. 17%, 18%, 15%, all based on claims of the previous year. But we do a lot of cost shifting. The healthcare costs go up for the people that are actually paying for it, and we've got to do something about our costs. The other problem that we face is we've solved the issues of infectious diseases. Okay? We can take care of infectious disease. But what we're dealing with now are chronic diseases, okay? As the population continues to age, we've got degenerative diseases that we are dealing with, okay? You're talking about arthritis, you're talking about heart failure, you're talking about kidney disease. These are all expensive to deal with. What's our incremental benefit, okay? So the question really becomes, how do we manage our cost? How do we improve the quality of care that our system is providing to patients, okay? And it all comes down to the AAA, which we'll talk about. But if you guys know this guy, Dr. Don Berwick, in 1991, they found the Institute for Healthcare Improvement. We know there's an issue in healthcare. We know we're not providing great healthcare, and it's costing us a lot of money, okay? So the AAA, 3 goals that they came up with, and the Center for Medicare and Medicaid Services has adopted this, okay? So when we talk about moving forward into healthcare, remember this framework, triple aim. So what is the triple aim? 3 goals, okay? So all of you either work for businesses, you know, business strategy always starts with a goal. You got a strategy, and then you got tactics, okay? Our goal is triple aim in this country. If we're going to achieve better outcomes, decrease cost, and improve patient experience, which also means improving quality, which is what triple aim is. I'm going to fly through some of these slides. Okay? So, improve health of a population, population health management. Who knows what population health management is? Raise your hand. I see a couple of hands go up. Okay? There are a lot of definitions to population health management. Okay? How do you define the population? What do you do for the population? Improve patient experience is the other goal under triple aim. And decrease per capita cost. Okay? So when you look around the room and you go into the exhibit hall next door and you look at the services that people are providing, one way or another, we're attacking these three areas of the triangle on the triple aim. Okay? If you're a tech company, somehow you're supporting one of these goals. Okay? If you're a provider, you're definitely supporting one of these goals. If you're a company like our company that's in population health management, that's services that we provide, support that we provide to a population that we've been given the risk for. Okay? So remember that, triple aim, improve patient care experience, reduce healthcare spending, improve population health. So what does improve population health mean? If you have a subset of patients that have heart failure, well, that's your population. How are you going to improve the health of that population? How are you going to make sure that the patient's taking care of their heart failure, that they're on the right diet, that they're not going to the ER, that they're measuring their weight, okay? Those that are in the remote monitoring business, you know what I'm talking about. You have weight scales that you can deploy into the home, or you have Bluetooth glucometers that you deploy into the home so you can get data on these patients to help manage their condition, okay? The other thing I want you to think about, and you can answer this question afterwards. Let me give you a scenario. You have a 70-year-old patient who's got heart failure, diabetes, hypertension, kidney disease. They're on about 10 different medications, okay? How much time do you think they have face-to-face with their primary care doctor? Yell it out. Anyone? Real time or quality time? No, real time. So when they go for a visit, how much time do you think they spend with the patient? How much? 10 minutes, 15 minutes, 20 minutes, 30 minutes. I want you to calculate about 4 to 5 visits a year, okay? And then think about, is that enough time for that 70-year-old patient? Can you take care of those chronic conditions in, let's say, if it's 15-minute visits 4 times a year, an hour? You can't, okay? Even if it's 3 hours a year, it's not enough. Okay, that's part of the problem. And we'll talk about some of the strategies. But since 2010 and 2014, population health management has accelerated. Triple aim is out there. If you don't know about triple aim, learn about it because that is the future. Okay? Not only in the Medicare space, Medicaid is also doing this. Now, the thing with all these government regulations and requirements, and we're pushing for better quality outcomes, reducing costs, what is it doing to our providers? It's burning them out, okay? There's a lot of requirements on our physicians and our clinicians. And the government's saying you got to do A, B, C, and D, and E, and F, and G, okay? We're looking at pay for performance for these providers, and I'll talk a little bit about volume to value, but physician burnout, clinician burnout is real, it's happening. We have a shortage of primary care doctors in this country, and it will continue. A lot of people are leaving medicine because of all the things that triple aim has done, okay? So the fourth dimension now that the government's looking at is physician burnout. How do we improve the work satisfaction of our providers in this country? And, you know, that's not the topic of discussion today, but look at all the things that you have to do. You have EHR requirements, okay? This goes back to what I was talking about. Everybody in the tech space, you're providing EHR services. You're trying to make things better for the providers, but for a lot of these providers, you know, taking a look at this stuff takes a lot of time. So a lot of dissatisfied providers out there, and if we have dissatisfied providers, how do you think they're going to deliver quality care to their patients, okay? If you ask the patient when they go see their doctor, and being a physician, being in clinical practice, I've noticed it, we all get jaded, okay? We start medical school to take care of patients. We have the right intentions, but over time, with the burden, with the stress, I was talking to someone earlier about bedside manner. Okay, it's important, but we lose that. And I don't want to say that for the entire physician, clinician population, but it does happen when you have scheduled 15-minute appointments to keep your lights open or on, your doors open. You've got to see in the primary care space, if you're not seeing 4 to 5 patients an hour, the margins are really thin. And we'll talk about what's happening in terms of value. Okay, so I don't want to spend too much time on this stuff, but we need to address burnout in this country. It's a real problem. Now, I don't know if you can see this cartoon very well, but it's just basically the patient saying, "I feel the way you look, doctor." The doctor's more sicker looking than the patient is. Okay, so true or false? Triple aim efforts continue to increase provider burnout. It's true. Okay, now let's talk about some of the things where the government's pushing to value. We talked about outcomes. And a lot of you may not be aware of this from a Medicare perspective, documentation and understanding Medicare risk adjustment. Okay? This goes directly to forcing our providers to really take a look at the population they serve, okay, from a documentation standpoint, in terms of the conditions. And the risk adjustment factor is how CMS pays health plans the right amount of funding for the population that they have been given risk for, okay? So the lower the RAF means that you have a healthier population. And if you know anything about contracting with Medicare and health plans, there's a county book rate, there's a premium that gets paid, and it's a base premium. So if the health plans want to get paid appropriately, they've got to raise the RAF, okay? That means revenue. And you have to prove to the payer, they're demanding accountability now, and they're saying that if you want more money to take care of the population that you're supposed to be taking care of, you've got to show us that that population is actually sicker. So let me give you an example. A patient that's an amputee, okay? There's a higher cost of taking care of an amputee. You've got liners, you've got prosthetics, source of infection, stump infection. That stuff doesn't get paid on the base premium to the health plans. They've got to prove, and the doctors have to document the conditions every year, okay? Do you guys remember Cinderella? Yeah? You remember what happened to Cinderella at midnight? Everything reverts, okay, back to the original. This is how RAF works in our country. Every year, the physicians have to document all the chronic conditions, okay, for the health plan to get paid. So this is another level of burden, but this is the government's effort to make sure that physicians are focusing on those conditions that are costing the system a lot more money, documenting it. So by documenting it, looking for it, what happens? They are made aware of the situation. So I'll give you an example, peripheral vascular disease. If on a 15-minute appointment, you can't necessarily pick it up if you're not looking for it. So this system is actually forcing the clinicians to target some of these high-risk conditions, start looking for the conditions because they're there in the senior population, and this system is now going to infiltrate the Medicaid and then eventually commercial, okay, lines of business, all right? We'll skip that slide, but documenting all conditions is important. Okay, quality measures. This is the other thing that Medicare is pushing. All our doctors in this country that are trained, they know they have to do the preventative stuff, okay? Getting the mammograms, getting colonoscopies or colorectal screening, okay? We still do a very poor job of achieving these things. So now the government says, well, listen, if we're going to pay you, you got to do all these things. And if you do these screening things, maybe we'll pick up conditions earlier. And if we pick it up earlier, we can treat them earlier. And if we can treat them earlier, what can we do? We can drive the cost down. Okay, I've told I've got 10 minutes, so let me get through some of these slides. But here are some of the measures that we're focusing on. Breast cancer screening, colorectal cancer screening, diabetes care, controlling blood pressure. This is all important. The other piece is, are our patients taking the medications like they're supposed to be? Okay? All right. We talked about patient experience. The patient experience side of the house, Medicare actually sends a survey out to patients. Talk to them about What's their perception of their health? Okay? What is their experience? And if these things don't get answered correctly, guess who gets dinged? The health plans get dinged. Okay? You don't achieve the star ratings that you want. The Consumer Assessment of Healthcare Providers and Systems, another survey that goes out to talk to patients about, are they getting the care they need? What's their customer service in their provider's office? What's the customer service with the health plan? This is all addressing patient experience, okay? All right, so let's talk a little bit about, in the next 5 minutes, I'm going to try to cover volume to value. And then I'll open it up for any questions so we can get done on time and we can get the next speaker up, which is going to fall right in line with this presentation, okay? So, Medicare enacted in 1965, and since then, we have been in what we call a volume-based model of healthcare, which means that the more patients our providers see, the more patients that the hospitals admit, the more money they make, okay? Yesterday, there was a conversation about profit, okay, how to make profit. Well, this is how they were making profit in healthcare. So what's happened? I showed you what the problem is, okay? So now what's happening is we want value, at least the payers want value, if they're going to pay for healthcare services. Medicare is the largest payer in this country, and they're demanding value. When you guys all go shopping, do you just throw your money away, or are you looking for value? Okay, now if you're an independent billionaire, okay, I get it. You don't care. But for the average consumer, why is Walmart so successful? Because they provide value. Now the government, the payers, they all want value for the dollars they're spending on healthcare, okay? So that's where we're going, value-based contracts. If you're a physician group, I'm sure insurance companies have come to you and says, how can we create a value-based contract? How can we shift some of the risk over to the providers that are actually managing the care for these patients, okay? Now, in terms of population health, you can read the definition, but basically it's a discipline to try to manage a certain population that you've been either given risk for or you've been given the responsibility for, okay? And what does that entail? So, for the tech companies out there, you know, you guys look at this and say, okay, how can we support the triple aim? There's many ways to do it. So some of the tools that we use and that the industry uses, risk stratification. If you can't risk stratify your population, how do you know which ones are the sicker ones? Which ones are going to use the health care more? How do you know which patients to target? If you have 60,000 patients that you are responsible for, or 60,000 members, the risk stratification comes in. I'll talk a little bit about notifications and alerts a little bit later, but we have care management platforms where you document what's happening with the patient, where you can invite family members, caregivers to log in and see what's happening with the patient, okay? Care gap analytics, which patients haven't had their screenings done, okay? These are all tools that we use, and I talked about RAF a little bit. There's a lot of stuff out there that, whether it's EHRs, there's a RAF calculator that you can add into the electronic health record for a provider so they don't miss some of these conditions, okay? This is all to help us get better at managing these populations. So these are the tools. So here's one of the tools that we actually use. And if you look at it and you can see it, it tells us which ones have an emerging risk. And if I click on it, it will give me a list of my patients that I need to target. The ones that have chronic risk, okay? And if you've heard of Johns Hopkins protocol, this is based on Johns Hopkins protocol, the algorithm. And so this is just an example of some of the tools that we use. Now, I talked to you about tactics, right? This is, in essence, population health management, okay? Transitional care. Patient gets discharged from the hospital. What do you need to do? You need to call them, okay? You need to find out if their services upon discharge were delivered, whether it's home health, okay? Did they pick up their medications? That's the transitional care. Complex care. Complex care is people with chronic conditions that may have 2, 3, 4, 5 different chronic conditions. The doctors can't get their hands around it, or the clinicians can't get their hands around it. Well, we provide service, and other companies like us will provide service where they have RNs that do face-to-face visits in the home. They try to assess the needs of the patient. This is something we can't do in our system currently at the doctor's office. So these are all support services that we provide outside and into the home, okay? Palliative care. We spend a lot of money in the last 60 days of life in this country. So, hospice is a great thing. But when people hear hospice, what do they think about? Right. Okay? So palliative care is another way of getting people services and more services to manage their symptoms, so, you're not going to get any additional benefit by getting them into the hospital and providing treatment. You're not going to cure their condition. They're not going to get better care, but you can give them compassionate care under palliative care, dignity for some of those end-stage cancer patients that don't want to go on hospice, okay? Emergency room care coordination. Now we have tools that alert us when someone's in the ER, okay? Now, if we can move that patient to an alternative site of care that's cheaper but the same level of quality or higher, okay? Hospitals are not great places to, dump people in. They're exposed to community-acquired pneumonia, and I just lost my screen. Okay. So that's the ER care coordination piece. There's also a network piece where we do SNF coordination when the patient gets discharged from the hospital to a SNF or SNF to home. Okay. So with that, are you able to get the last slide up? Okay. There's another piece, while they try to get this up, there's a thing called social determinants of healthcare. How many of you know about social determinants of healthcare? Okay, that's very important. These are barriers, whether they're economic, transportation, whatever it is, there's a spectrum of social determinants that prevent the patient from getting health care. And if you're going to do population health management, you've got to provide solutions to these barriers for these patients to get the care, okay? Prime example, transportation. If you can't pay for your medications, you're not going to take your medications, okay? So what kind of services are there in the community that can help the patient pay for their medication? How can we get transportation? Do they have food? And I'll tell you, there are a lot of patients that we see that if you go into their homes, they have nothing in their refrigerator. What do you think is going to happen to that patient if they get discharged from the hospital? They go to the home, maybe they have a caregiver at home, maybe they don't have food, they're going back to the emergency room. Okay. I do want to show you one picture and then I'll call it quits. Okay, why don't I take questions while they're trying to bring it up? Because I do want to show you a real-world example of what someone's home looks like that one of our nurse practitioners went into, okay? Just to kind of put things into perspective that, we all may live in great communities, great homes, but that is not the case with all of our patients, okay? Questions? Yes?
So I have a downstairs neighbor who is bipolar, who has no money. There's never any food in her fridge, so I understand where you're coming from. I'm just curious, after everything that you said, how you feel about the whole Medicare for all, Medicaid for all, because I know that Medicaid pays way less than United Healthcare, and, well, Blue Cross is not, they don't pay that much. In Florida, sorry if you're from somewhere else and they pay higher. Cigna pays pretty well. I'm just curious, I feel like doctors are moving away from Medicaid and Medicare because they don't get paid enough and they do the same work. And if they do take Medicaid or Medicare, they kind of slack a little bit. That's what I've noticed. So
Okay.
I just want to know what your opinion is, since you seem to be kind of an expert in this area.
So I will tell you that you're absolutely correct when it comes to Medicare reimbursement and Medicaid reimbursement. Some of the costs, even to the hospitals, to the providers, the payment to these providers doesn't even cover their costs. So a lot of providers don't take Medicare. Okay, that's a problem. Our population continues to increase. Some of them don't take Medicaid, okay? Now, if you look at Mayo Clinic, at least in Arizona, they don't take Medicare. So if you have Medicare fee-for-service, you can't go to the Mayo Clinic, okay? Now, so this is where, when I was talking about value-based contracts, this is where Medicare is pushing not only the health plans on the Medicare Advantage side, on the ACO side, how do we deliver more money, not under a fee-for-service mechanism, but how do we deliver more money to the provider under a value-based contract where you can earn a lot more. So I'll give you an example. We talked about RAF, right? So I have providers in Arizona and Casa Grande that I pay bonus checks to because of their performance on outcomes. Well, for 500 patients, they can get close to $240,000 in incentives. And everybody is doing this, okay? So if you are open as a provider to understand the pay for performance system, then there is revenues there. But if you strictly look at, okay, I see a Medicare patient, this is what I get paid, it's less than United, it's less than Cigna, it's less than Anthem. That's true, okay? Now, Medicare fee-for-service doesn't pay these incentives unless you belong to some kind of ACO and you get some savings, or the patient belongs to a Medicare Advantage plan, okay? So this is how they're trying to close the gap in reimbursement and get providers to take on more. Now, your question about Medicare for all, I'm not going to answer that question. I don't want this to be a political debate, but I do agree that there has to be universal coverage. Yeah. How we pay for it is debatable, but there has to be universal coverage, and this goes back to my point talking about cost shifting. If everybody has coverage, like under the Affordable Care Act, they were trying to get coverage for everybody, the cost shifting cycle will stop, okay, because everybody has some form of coverage, okay? All right, look at this place. This is actually in Coolidge, Arizona. Look at this house. You think these people are healthy? No, okay? And then you will find things like this in people's home as well, okay? So with that, I'll answer any last questions.
I have one for you.
Yes, ma'am.
So you talked a lot about Medicare and the value for performance. But on the employer side, we see this huge increase constantly on the employer side on a cost that's being offloaded to the employee on high deductibles. So do you see that transition that Medicare is doing with this value-based performance transferring over to the private sector, like a Mayo Clinic, and having to, do a fee for instead of a fee for service?
So on the employer side, those that are big enough, if they're self-funded, okay, there are programs and platforms to help employers manage their employees, okay, in certain areas. The problem on the commercial side, when you look at what you're paying for, if you have families, you've got patients that are pregnant, you can't keep them out of the hospital, there's a cost associated with that. If you have beneficiaries or kids with cancer, those are high cost dollars. Now, what I will tell you is that there are a lot of companies out there that are going to self-funded health, employers, and what they're saying is, we will help you manage your population, whether it's through health coaching, identifying your claims, and if you really look at it, if you're a big enough employer, the best way to go is to do some kind of deal with providers directly. And I'll give you an example. In the state of Washington, Boeing did a deal, I want to say about 3 years ago, with University of Washington Healthcare Systems, where what they did was they took looked at what it was costing Boeing to provide health care, and they did a direct contract with providers. So this is where it answers your question about value-based contracting. If you contract with a health system and you're big enough, you're cutting out the insurance companies that are taking a certain percentage of the premium and any other middleman. And that's where you will see, rather than seeing an increase in your premium every year, you can manage that, and you can actually put the risk of those dollars on the provider system and say, we'll pay you 20% less than our historical cost. You have the dollars, you manage the risk, you improve the quality. If you can do it, you can make a margin, great. I mean, that's where they're going. And even in the commercial space, the things that apply to these patients will be important in terms of quality measures, clinical measures, those kind of things. So it is coming to the commercial space.
Question over here. So my first question was about direct primary care and what your thoughts were on that. Last year, I'm a part of a startup of a company that we are basically doing DPC with a number of providers, not just primary care. So we've partnered with physical therapy, radiology, some limited pharmacy based on a formulary, primary care, as well as some mental health. And basically for a monthly fee, you get unlimited access to this network. And we've tried to introduce this to self-funded organizations, whether government or non-governmental organizations, to help try and cut out that cost exactly as you say. So I'm just wondering what your thoughts are on that. The other piece to that too is these health sharing companies. We've partnered with a non-religious, because most of them are most of the health sharing companies are religious, but so we've partnered with a non-religious one that covers kind of the catastrophic piece of that to partner with the primary care, I guess, direct primary care products. So, sorry.
Well, you bring the same concept as that was brought up earlier, where if you're delivering a network, to self-funded employers, and this happens with health insurance companies as well in markets where they don't have a developed network, but if you have a network that can deliver value, provide access, and you are actually controlling the cost for the employer, it's a great model, okay? Because everybody, in this country, if you're familiar with how employer-based healthcare came about, it is employer-based healthcare unless you're on Medicare or Medicaid, right? It's a benefit. And it was a way to compete in the old days with other companies to provide healthcare benefits rather than these employees paying higher taxes if you were paying them income. So the model that you're talking about in developing a network and having network providers, whether it's primary care, specialists, PTOT, home health, and you can provide unlimited access at a certain fee and drive the cost, the most important thing is getting care to the patients when they need it, okay? Historically in our country, we deliver health care when it's convenient for the healthcare system, not when the patients need it, okay? So I will tell you that if that's what you're doing, it's great. And there is a whole market on the self-funded space where a lot of these companies now, even with 100 employees, you can go and do a partially self-funded plan where you're not giving all your dollars to the insurance company. And if I guarantee if you go back and you look at what your cost as an employer is, it is on a steady incline every year. And I've experienced this. You're looking at a 10, 15, 20% increase every year, okay? Now, some health insurance companies, if they give you a partially self-funded plan, they'll give you some of that premium back, okay? But that's not always the case. So what you're doing is great.
We
Okay?
need to finish up here, if you can. You want one more question?
Well, I'm not sure if it's national, but in Florida, if you're over 50 employees and you're self-funded, the HR department gets to pick what they cover and what they don't. So for example, if you have a pre-existing condition, that rule is up to the company. So like Baptist Health System, which is a multi-billion-dollar health care company, multiple hospitals, they don't cover a lot of major healthcare concerns, which is ironic because they're a hospital system. But they are allowed to choose, and all of their employees have to pay into, that self-funded through another insurance company,
Yeah.
And what do you think that's going to change anytime soon, or do you think that's just going to stay
Well,
where
I
it is?
think you've got to clarify one thing. Pre-existing conditions under the Affordable Care Act, every insurer has to cover it, okay? And that started with kids and then everybody else. So in terms of benefits, employers can choose. All they're required by the Affordable Care Act is to provide essential health care benefits. Okay. No, I get it. But the Affordable Care Act dictates in terms of if you're an employer, what type of health insurance coverage you have to provide, and the coverage that you provide if you're self-funded, someone has to be paying the claims. You might get a TPA, but the benefits that you have to meet the minimum standard. If you have less than 50 employees, you can tell your employees to go to the exchange if you have a state exchange, right? And get health care and purchase, and you can either pay or subsidize that cost, okay, for your employees, but pre-existing conditions have to be covered. This is where this gets back to the question of Medicare for all. Do I think, you know, if it were up to me and if I were running this country, I would do something similar to what the military has done with TRICARE, okay? The military with TRICARE, what do? They know what their cost is, and for beneficiaries, so they don't impact the military treatment facilities, they push that care to the private industry and say, okay, here are the dollars by region, you go manage the care, you go manage the cost, okay? We could do it where you don't disrupt the private health industry, and okay, if you work for the government, I'm sorry, but the government is always inefficient in terms of when it comes to managing things. So let the private industry manage it, but have a single insurance fund where if you're between jobs, if you're moving from state to state, you're always covered, you always have health care, and you always have benefits, and how we pay for that are in the details, but conceptually, I believe in universal coverage, and the question is, how do we get there? And I think that at some point, we will get there. I just don't see that happening in the next 5 years with the political climate, so.
There was another point that you brought up. Medicaid and Medicare, a lot of the checkoff for services that a doctor that works for Medicaid.
Can someone give him a mic, because I have a hard time hearing him. Sorry.
But Medicaid and Medicare, a lot of times, in my experience, the treatment plan gets sent to a doctor that is not specialized in that type of treatment, so they deny it. I don't know if that happens in every state. I hope it doesn't, but it happens in Florida 90% of the time. So they say, oh, well, they have Medicaid, but I don't understand what you're trying to do with this client. So it's denied, because I don't get it. Like, a kid can't brush their teeth. Well, eventually it's going to be thousands of dollars for the kid to get their teeth replaced. But the doctor doesn't understand that.
Yeah.
So what's your thought? I'm just curious of the future, because this is all about the future. You know, this is advancement in healthcare. And I'd like to hear more about advancement.
So I will tell you that change takes time. And when you start looking at people denying claims, you know, I ran a prior auth department, and I will tell you that we do have a real problem when it comes to insurance companies or that people that are managing, and when they look at claims, there's so much volume that comes through there, and they follow criteria, okay? And what usually happens is they'll have a nurse that reviews the criteria. I don't know if you remember a couple years ago, I think it was one of the big insurance companies, I think it was Anthem, where the medical director said, oh, I never really even saw the documentation. I saw what the nurse did, right? Well, that has to change. And we have to change our paradigm in terms of what is appropriate care. I would rather spend the money on the outpatient rather than spending the dollars on the inpatient. So like you said, if you got the preventative care and you paid for it, you're going to prevent the long-term consequences. And it's a mindset that needs to occur at the payer level to understand that humans are not a criteria. Human care can't be delivered on criteria. It has to be based on what you see and what is not only cost-effective, but high quality. And a lot of these insurance companies are mired by, oh, I get 100 requests every day from doctors to prove items. Well, to me, you know, I understand that 30% there's abuse and fraud in the system. I'll tell you what, provide the care, let's do retrospective review on the cases and find out who's actually abusing the system, right? But let's get the care to those patients, and then let's deal with the folks on the back end, and that way you're not going to have that issue. But that's going to change a major mindset, maybe even government regulations. So there was one other question. I'll make it the last. I don't want to take up too much time. We got to go. Okay. Thank you for your time this morning.